Hello, everyone. I'm Dr. Kevia Taylor Sullivan. I'm one of the generalists in the Department of Women's Health here at Harlem Hospital. Our chair, Dr. Mandeville, is back there as well. So we've had some fantastic discussions. We are going to continue with the theme, improving the health of the elderly Black population from a gynecological perspective. Appropriate gynecological screening is one of the most impactful and cheapest ways that we can promote the health of elderly Black women, particularly cervical and endometrial cancer, which disproportionately affect Black women. There was just some information published in the Cancer Journal just this year that reveals cervical cancer mortality rates are highest for Black elderly women, and they were 77% higher than what was previously calculated. The explanation for this underestimation is the way that it was calculated. In past calculations, they included women that had underwent a hysterectomy for benign indications, and there are some benign conditions that disproportionately affect Black women, like fibroids and abnormal uterine bleeding, largely from obesity, that will increase their risk of needing a hysterectomy for benign indications. So that skews the data in the direction of a low cancer risk. But when they did the corrected calculation, what they found was Black elderly women are actually have the highest mortality rate from cervical cancer. I do think I have some. Okay, so in women older than 65, 25%. We have a 25% incidence of cervical cancer, and 40%. We make up 40% of the death from cervical cancer. The corrected mortality rate after correcting for hysterectomy was 10.1 per 100,000 compared to what was previously seen, which was 5.7 over 100,000. That's a pretty big difference compared to white women that also their risk was underestimated as well, but not to the degree that Black women's risk was estimated. And again, that's largely because of the risk because Black women have a higher rates of hysterectomy at younger ages for things like fibroids and abnormal uterine bleeding. And here we have a slide that shows the age-specific cancer mortality rate uncorrected and corrected. This is just a graphic depiction of what we just discussed. So realizing that our cancer mortality rate is very, very high and 77% higher than what was previously predicted, this underscores the importance of cervical cancer screening, right? And this is just hysterectomy corrected cervical cancer mortality rates that reveal a larger racial disparity in the United States. This is what we just covered if you look at it by age. So even though we know how important cervical cancer screening is in our elderly population, 14% of women aged 65 to 74 have never had a pap smear. A lot of practitioners, especially those of you that provide gynecological care for your patients, we think that at 65 we just stop screening. But remember, the screening goals are the same, especially in a very robust, mature woman. They are the same as they are for younger women. And 39% of women 75 and older have never had a pap smear. This is absolutely unacceptable because cervical cancer is preventable. No one should be getting it, and you certainly should not be dying of it. It's a little complicated, too, to keep track of the screening guidelines because you have multiple organizations that put forth their guidelines. But generally, in a perfect world, we can stop screening at 65. However, we see that a lot of women, mature women, don't meet the criteria for stopping screening. And those women include women that have inadequate prior screens, women that have an HIV infection, and we know that Black women are disproportionately infected with HIV, and that will certainly increase your risk for cervical cancer. And in fact, women that are HIV positive, they require lifelong screening. In fact, the only elderly women that you would not screen for cervical cancer would be those that you expected to have a survival rate of less than 5 years. Otherwise, you should be doing the screening. And any woman with a history of moderate or severe cervical dysplasia, they require screening for 20 years after the satisfactory treatment of the dysplasia. And again, we already talked about a life expectancy of less than 5 years, and you would not screen those women. And these are just quartiles of average life expectancy in elderly women. And here you can see what they are. At age 95, the majority, all quartiles have a life expectancy of less than 5 years or less. And this is just something that I found interesting. The life expectancy for Black women's life expectancy outpaces that of both Black men and white men. Now, the second cancer that we are going to talk about is endometrial cancer. Endometrial cancer disproportionately affects Black women as well. It peaks between the ages of 70 and 80, and to screen for it, you just simply have to ask, do you have postmenopausal bleeding? And the workup for it is so basic. With a simple ultrasound, if the endometrial lining is 5 millimeters or less, you can exclude endometrial cancer and just make the appropriate referrals. A large amount of endometrial cancer is also linked to obesity. And for women across all age groups, you can see that the incidence rates of cervical cancer are increasing. And I think that's largely a function of obesity. Interestingly, smoking is protective for endometrial cancer, but that's not a reason to smoke. And here, so if you go back, you can see that the Black women, the red line, our rates of uterine cancer, they are increasing, but we don't make up the highest incident, but we do have the highest death rate from endometrial cancer. One explanation could be the prevalence of the type 2 endometrial cancer, which tends to be a lot more malignant and is linked to obesity. And other than screening, here are some other explanations about health disparities among Black elderly women. Sometimes Black elderly women can face bias. It could be factors related to socioeconomic status, health behaviors related to culture, people thinking that screening is of low priority, access to health care, certainly environmental factors, direct and indirect manifestations of discrimination, and physician tendency to limit aggressive treatment in older patients, right? So just in closing, I would just like to quote Shirley Chisholm, "Service is the rent you pay for room on this earth." Thank you.